Hello, everyone. My name is Dr. Reg Omangi, and this is.
My name is Nas Nyambura.
And welcome to today's live. Today, we're going to talk about a very niche topic. Uh, it's a very specialized topic, but very important nonetheless. It is hemophilia. It affects a significant portion of the population, albeit small but significant. And we're here to talk about what it is, how to manage it if you do have it, how to deal with either you or family members or friends with this condition, and how to essentially manage and live with it. So we're just here to give our insight on what we know about the disease and how best to help, essentially. So we can just start by uh, throwing a few questions to my colleague, just to explain to us from her perspective what she sees hemophilia as, how she understands hemophilia, and we move forward from that with our scope of knowledge. So
Okay. My understanding of hemophilia is a deficiency in the clotting factors. Most common types of hemophilia is the hemophilia A and B. Then also there's the acquired hemophilia, which comes about as a result of maybe most common patients are the alcoholic patients due to liver damages,
yes,
since most the clotting factors are formed in the liver. So, in a nutshell, hemophilia is a deficiency in the clotting factors. So it leads to bleeding, which is also a bleeding disorder. So, yeah, that's my understanding with
okay,
hemophilia.
that is very correct.
Yeah.
So in summary, or as we talk about hemophilia is, for the most part, it is a bleeding disorder. So it is a bleeding disorder, mostly genetic. There are many categories of hemophilia, but it is, as she said, a deficiency in clotting factors. And for the most part, for 3 out of the 4 versions, 4 types of hemophilia are inherited. So mostly hemophilia, when we talk about hemophilia, we're talking about an inherited genetic disease. It is a genetic condition that is passed down from generation to generation. And we're here to talk about some of the myths and some of the misconceptions and what essentially it is. So for the most common part, we'll talk about the most common uh, types of hemophilia. So we have hemophilia A, which is a deficiency. So first of all, even before I start, typically in a normal human with normal physiology, there are 2 different pathways of blood clotting, because this is a bleeding disorder where there's a deficiency in the clotting factors, which predisposes you to prolonged bleeding. So it's not about bleeding a lot, it's about stopping bleeding. So there's a process in the human body called hemostasis, which is just the stoppage of bleeding. And this is where the issue is when it comes to hemophilia specifically. So I will just talk about the clotting cascade. So there are different ways our body tries to clot blood. And rather than explaining it, I'll try and just show. We're outside, so I don't know if it'll be as visible, but there are multiple coagulation pathways that our bodies go through. So there's an intrinsic pathway and there's an extrinsic pathway. So I will somewhat describe this. So all these are different proteins or factors, as we call them, that when there's tissue injury or when there's a cut specifically, or any damage to either the vessels or tissue like skin, depending on the mechanism of injury, depends on the pathway. But all of these lead to different clotting factors that cleave one to another. So this clotting factor, let's say clotting factor 7, turns into 7A. 7A it turns protein factor 8 to factor 8A. This comes to now factor 5. And all this eventually, just to not dive too deep into it, all this now creates a protein called thrombin and fibrin. So when it comes to fibrin is in the body, in your blood, there's a protein called fibrinogen. So when it's called fibrinogen, when it's in this state, it is soluble in blood. So it's just floating around, very much soluble. But when when fibrinogen is converted to fibrin, it coagulates and forms a sort of it's like a mesh. It coagulates and forms some sort of mesh, and now this mesh patches. If you can think of your blood vessel as this pipe, and there's a leak in the pipe. So what fibrinogen does, once it turns to fibrin, it comes and patches that area. And together with the platelets, it's a whole. So when this mesh forms, platelets and red blood cells will aggregate to the space between the meshes that's essentially plugging the hole. So all fibrin is this mesh that we use to plug the hole that is your blood vessels. So all these different factors that we were talking about today do lead to that fibrin mesh. And I don't know if it's visible on the screen, but I'll try and show you this fibrin mesh. So this mesh somewhat forms, and that's where your red blood cells clump. So when they clump, they form the clot. And sometimes when you look at the scab, that plug, so it forms a literal plug on your vessels. That's the plug sometimes we see whenever we get a cut, that scab, it's from dried out red blood cells. And now when you look at hemophilia, not it is. And whenever stoppage in the chain, you don't end up with this plug per se. So that's where now hemophilia comes in. It is essentially an inherited bleeding disorder that causes impaired clot formation and excessive bleeding. So very slow, very long bleeding times. So people with hemophilia tend to bleed longer. So there are many ways someone would present with hemophilia per se. So there would be easy bruisability. Not naturally, we bump into things as we walk. Sometimes we don't even feel it. And some of these damages do happen, but our body fixes it instantly. So you may bang your arm on a desk, and that does cause some tissue damage. And it may cause some micro tears in some of the vessels, but your body does a very good job of plugging it immediately and stopping the bleeding. So you never even see the bruise. But now in someone with hemophilia, they will bump, and because they have delayed clot formation, a bruise or a hematoma will show up under the skin. So there's easy bruisability. These patients will find that they are bruising all over their bodies, just sometimes even without any trauma history, which is hitting yourself anywhere, any injury. For some of these patients, when they go and brush their teeth, their gums will bleed easily, and they'll tend to bleed for a longer time. These patients may present with nosebleeds, very frequent nosebleeds. So all the time, patient comes to you and says, I'm constantly nosebleeding, I'm constantly nosebleeding, and there's no necessarily history of trauma or any allergy. So you want to investigate and see what this could be. And most of the time, or some of the time, you find that it is hemophilia. So how do we manage it? Or what are some of the myths that I've heard about hemophilia? So people tend to say hemophilia only tends to affect men. That is inherently false. As much as the truth is, it tends to affect more men than women, because it is an X-linked, what we call hemophilia is an X-linked gene, or an X-linked genetic disorder, which means this disorder is in the X chromosome. And as we know, for men, it is the sex chromosomes that we have are XY, and the sex chromosome that women have is XX. So sometimes, so when it comes to passing down the gene, as long as I, a man, do get one defective X chromosome from my mother and the Y from my father, I will tend to present with hemophilia because the other Y chromosome does not have the other gene that would counteract the defective X gene. But in ladies, most of the time they'll tend to be carriers because only one X chromosome some of the time will be affected. But so women will also tend to have hemophilia, just sometimes in either a mild form of hemophilia or they may be carriers. But when it comes to men, because it is X-linked, there's a higher chance of a male child presenting with hemophilia as opposed to a female child. So typically when we're looking at hemophilia, genetic testing is extremely important because now we have to try and cancel the couple, because if, let's say, patient X, which is Nyambura, would be a carrier, which means she has one X defective chromosome with the hemophilia gene, and I, who is XY, I am hemophilic. There's a high chance of our child with that combination will most definitely get hemophilia. And if it ends up being a girl, there's a high chance that that girl will have full-blown hemophilia, or at least be a carrier. And if it's a male baby, there's a very high chance that hemophilia would step in. So it is very important to take couples through genetic testing and genetic counseling so that they can decide, maybe our children would not be genetically compatible. What are the options? And it's very important to take patients through this and just explain to them, explain the risks of having children, explain how to live with the children if they already have children with the disease. And that's what we're going to discuss next. So I would pass the baton back to Nyambura and explain to us if you've interacted with any hemophilia patients. Do you know anyone with hemophilia? How have you seen it affect patients, not only physically, but mentally as well?
Yes, I've interacted with a patient with hemophilia. Unfortunately, it was a child. So I think the most disturbing thing for the mother was, will my child live a normal life with hemophilia? What do I have to do for my child to avoid bruises? I think my child is not supposed to engage in sports in school. But then you have to encourage them that, yes, this child can engage in sports, but it has to be a type of sport that is not contact. We don't expect this child to play something like rugby, but we expect the child to involve him or herself in something like swimming, more of the soft sports, things like playing tennis, think badminton also.
Yes, badminton.
Yeah, these soft spots. So you find this thing really affects people mentally. You can find someone who really is a child is really into football, but they are restrained by the condition that they are in, because like you've said, most hemophilia is genetically, so it's not something we expect like take medication,
Yes.
goes off. Yeah, it's something like you have to live with for life.
For life.
Yeah, so you find it really affects some people mentally also. Yeah, like I've said, a child wants to play football, cannot play because of his or her condition. So the thing we do is we encourage our patients.
Yes.
Yeah, you're not limited to the type of life that you live, but at least enjoy the activities that you can. Yeah, engage yourself in supportive activities with your life, and also accepting
Accepting the diagnosis.
accepting the diagnosis, because there's the management that is taken, like replacing the clotting factors that are missing. I think there's that
Yes.
and there's also these symptoms of bruising
The
in the
easy
knees.
bruisability, yes.
Yeah, so you find it really touches them mentally. So Yeah, that's the encouragement I can give to someone outside there who is experiencing hemophilia.
Hemophilia.
Yeah, it's never the end of life.
Yes, it is not.
Yes, it is not.
Hemophilia is not a death sentence,
Yeah.
as people may think. There are many people who are living full and healthy, happy lives with hemophilia. As we mentioned, it is a bleeding stroke clotting disorder. So it is not a death sentence. It's something you can live with. We just have to make some lifestyle modifications around your condition. So we start by now understanding how best to manage the disease. And first would be now the mental stroke emotional aspect, as my colleague was mentioning, which is extremely important because this is a lifelong disease. And typically in medicine or in healthcare, you realize that mentally when mentally a patient is not okay, it manifests physically. So one, we need to manage the psychosocial aspects of the patient. So trying to reassure them that this is not the end of the world. Hemophilia is very much manageable. It it does not mean that you cannot be physically fit. It doesn't mean that you cannot exercise. We just need to take care of yourself a little bit more than the general population. And there are various forms of management. One would be factor 8, which factor 8, the von Willebrand disease, is the most common version of hemophilia A. So for most of these patients, if they do have a bleeding episode, they just come to the hospital and they do get the factor 8 concentrated infusions. And that we're just replenishing that factor. And that factor tends to now take over clotting because it is just, as I mentioned, it is a whole cascade, or it's a whole chain where this protein converts this protein into a different version of itself, transfers. So it's just that the chain is broken. So when we give you that infusion, we are closing that loop, we're closing that chain of the cascade. So once we give you that, it it pushes you for some time because it is one, the liver's job to produce these proteins, and these proteins do denature after a few months, stroke weeks, depending on the factor. So that is the most common modality of management per se. So we start with the infusions. We also, for people who tend to bleed a lot, for severe cases of hemophilia, they can also schedule hematologist reviews where now they get the same factor 8 but prophylactically as a preventive course. So just every week, actually, you'll find every week or every couple of days, it depends. This now comes to the discretion of the hematologist following you up. They will decide with your severity, with the tests we've seen, come in this number of times for infusions just to replenish that protein, as I was saying, this factor that's very important. And other medications is called emicizumab. My pronunciation may be a little bit poor, but it is a monoclonal antibody that acts as it acts as factor 8. So it somewhat mimics factor 8, and in that way we also tend to now fill in that gap with this specific drug. Another very common drug in active bleeding with these patients is desmopressin, which causes its main mode of action is causing renal reabsorption of water. It mainly acts on the vessels, but as a side effect, it also increases factor 8 production by the body. So with hemophilia, it is not necessarily that they do not have this factor, they just have a very small amount. They're deficient in this factor. So desmopressin tends to boost production of this factor 8, and it also tends to boost another protein called tissue plasminogen, which also helps with that chain, closing that loop of that chain of clotting. So there are many ways of managing this condition. As my colleague said, we'd now move to the lifestyle. We've talked about the medical aspect of it, but she talked about now avoiding contact sports like now rugby, football, because now you're going to bump heads, you're going to bump elbows with other people. And this will tend to cause bruising and bleeding per se, especially with rugby. With the heavy tackles, you can easily cause internal bleeding. You can cause bleeding in the muscle tissue or even in the organs. So we tend to just tell them to avoid. With children with hemophilia, we tend to now put some extra care, especially with the boys when it comes to circumcision. Any surgical procedure, if you're living with hemophilia, there always needs to be a hematologist on board so that they can follow you up and supplement the factor so that if any procedure is to occur, bleeding isn't an issue, so that hemostasis is achieved per se. Uh, Factor 8 is it is a protein in blood that is part of that coagulation cascade. So when I was talking about the coagulation cascade, there are multiple proteins. There are many, many, many different proteins that are just floating around in your blood. They are all soluble. So when there's tissue damage, when I was talking about the intrinsic versus extrinsic pathway, these are different pathways that trigger clotting. All these pathways trigger clotting. So the extrinsic pathway is the trigger is air. So when blood is exposed to air, the platelets are activated and they produce various factors that now there's some proteins that are now converted from, let's say, factor 7 to 7A. Once it's exposed to air, it changes shape. And when it changes shape, it locks into another protein. As I was saying, it's a whole chain. So this protein, you can think of these proteins as maybe one is fork shaped and one is C shaped. So they cannot interact with each other while soluble. But now when something happens like exposure to air, this protein changes shape. So now it's able to fit. So once it fits with this protein, it cleaves it or breaks it down, and this other protein changes shape again, and it links to another protein. So this whole chain happens. So all these proteins are hanging around, floating around together, harmless. They don't interact with each other. But once one protein is triggered and it changes its shape, it now forms a chain reaction that eventually leads down to now fibrinogen, which is soluble, being converted to fibrin. Then now that mesh is formed. So factor 8 is just one of the proteins that is usually affected with hemophilia. So the gene that tells the liver produce factor 8 is defective. So the liver is not able to produce enough
Enough.
of it to push down the chain. So you'll get this damage where you'll get a cut, but you will find that factor 7, all the other factors do their thing, but once it gets to factor 8, there's not enough of it to trigger the chain reaction down the slope. So that's what factor 8 is to the person asking the question. And when we're talking about now acquired hemophilia, because here we're talking about genetic, Nyambura mentioned acquired hemophilia. So in cases of now malignancy where the liver is affected, or with people with liver disease, especially alcohol-induced liver cirrhosis, the liver stops producing enough of these proteins. So now even your clotting factors are depleted, then now leading to the same hemophilia issues that we were just discussing. So mostly it is a genetic disease, but sometimes you can acquire it through either liver disease or other infections or conditions that would eventually affect the liver per se. So back to the point of living with it. So constant, very consistent hematology reviews. You need to be followed up by a specialist, a hematologist, so that they can walk you through, because this is a long-term disease. You need a specialist to follow you throughout your life, just with the management. And another would be whenever you're going to a hospital for any procedure, be it even an IV injection, you have to let the healthcare worker know that I have hemophilia. What do we do about it? So even before just any injection, we have to make sure that your clotting factors are an adequate amount. So we might decide to do an infusion of factor 7 or factor 9 or 11, depending on which hemophilia you have, then now do the procedure.
And that includes dental procedures.
That includes dental procedures, exactly.
Yeah. And for the pregnant mothers, we should always enroll the high risk clinics.
Yes.
Yeah.
Yes. Thank you for that point. So, pregnant mothers, especially with hemophilia, that is already considered a high risk pregnancy because you are predisposed to various. When you have a bleeding disorder, you're predisposed to various pregnancy complications like placenta abruption. So you need to be followed up by a high risk ANC clinic per se. So yeah, that is a small summary. In summary, when it comes to hemophilia, it is an acquired, it is a genetic disease that can also be acquired. It is not the end of the world once you're diagnosed with it. It is a disease that can easily be managed. It is a disease that we need to destigmatize, especially when it comes to children. We need to reassure them that you're not any different. You are you are no different from other children. You're still just as smart, just as good. It is just that there's something off with your blood coagulation, and we just need to take care of you a little bit more often than other kids. So it is not a death sentence. So it is very manageable, especially in our setup. So I hope you guys have learned something about hemophilia. We're open to any questions that may
And also,
come our way.
talking
Yes.
about the destigmatization part, it's always advisable to wear the bracelets, the
Yes.
identity
Yes.
bracelet saying you're hemophilic or I'm undergoing this. So, because you may never know when an emergency may land on you, yeah.
Yes.
So at least whoever that the doctor that might be handling you, and there's no one to say like this person is hemophilic, this person is like this. At least they're able to know to check your bracelet and they're able to know the care to give to this person. Because maybe you might be bleeding in an emergency room and someone may just concentrate with the fracture that you have had, and probably it's because there's a clotting factor that is missing in your system. But when you have that identity bracelet, someone is able to know like, let's first deal with this so as we can manage this.
Yes.
So it's something people should be encouraged to be wearing, to avoid the stigmatization and feel at ease having it in their.
It is very important because nowadays there are many companies in Nairobi that I've seen where you can get dog tags, you can get bracelets. Most smartphones nowadays have a feature where you can put your emergency medical information on your lock screen, so that even if you are unconscious, someone trying to unlock your phone can easily see down there that there's a medical, I think Apple calls it medical ID, Samsung calls it, I think, medical information, something like that. So you click, it shows you, this is my name, this is my age, this is my blood group, if you do know your blood group already, and any conditions. I am hemophilic, I am diabetic, blah blah, whichever condition that is extremely important for the doctor to know in case you are incapacitated. And another thing to do for patients who are hemophilic, when you are bleeding, either a nosebleed or you get a cut, what I would advise is placing firm pressure on the wound. Just firm pressure, just trying to manage the wound as much as you can, because clotting takes time for you. So you just try and hold pressure as you head to the nearest healthcare center so that we can help you stop the bleeding by now infusing you with the depleted factors that you already have. So yeah. Any question?
What is one key thing every viewer should remember about hemophilia?
One key thing. That, as we said earlier, that it is not a death sentence. We should not stigmatize people with hemophilia, but it is important to be aware of what it is. And if you know someone with hemophilia or have heard of someone around you with hemophilia, try and, one, share this video, and two, try and support them by just talking to them, asking them, do you have any contingencies in place? And just reassuring them that you are there for them, because this is a disease that people tend to feel alone. So just making people around you know that they are not alone. Yes. So that would be my parting shot.
One key thing you'd like viewers to know about hemophilia.
Uh, I would say hemophilia. Uh, it's I would say it's a condition where you just have to be cautious with what you do. Yeah. Despite it is limiting you to some activities, uh, they should always know they are not so limited in doing activities, and also it's a condition you can live with. It is not limiting you to the type of relationships you'll get in. Despite what the doctor said here, Dr. Rage, that it's always important to do the couples, what do you call it? Genetic
Genetic counseling.
counseling. Yeah, it is not limiting you to date someone, but at least it's always good to engage yourself in the couples genetic counseling, so as you can be able to plan your future. Yeah, that's what I can say.
So, guys, thank you so much for joining our live. And my name is Dr. Ridge,
My name is Nyambora.
and see you next time. Thank you.
Thank you.